So good afternoon, everyone. You are most welcome again to QPS TalkTime, and this is episode 13 of the year. It's our second episode of the season. We've had a lot of interest in today's topic, which is great, and we are expecting a pretty full house, which is to be welcomed. I'm just going to, while we're waiting for people to log in, I'm just going to share, I suppose, some information regarding the resources that NQPST has available, and then we'll move on to introduce the session in a moment. So just while people are joining, it's great to have you with us. If you've been with us before, welcome back, and if it's your first time, I hope you enjoyed the session with us. But I just want to make people aware of the resources that are out there, and there is fantastic resources available through the internet, through NQPST. Some of them here on the slide. So just making people aware of the Q community. Very much encouraging people to check out the Q community, which is based throughout Ireland and the UK, and certainly we would encourage people to check out Q. You can become a member. You do have to apply, and we're happy to give you any guidance or help in what that entails. But you can also avail of Q without being a member. There's lots of resources. There are meetings, and one of the nice things is that you can connect with people across these islands that are involved in similar projects in improving quality and safety, and you can share experiences and get them to help and ask and answer questions. So it really is a community. World Patient Safety Day was recently, and just to highlight some of the resources that are available, the QR code will take you to that, and especially just highlighting the Your Health, Your Voice materials, and would encourage people to check out all of those things, including the podcast that we did to mark World Patient Safety Day. The QI prospectus, again, QR code there will bring you to that. And that really captures all of the resources that are available, many of them online, but also in-person courses that NQPS either runs or sponsors. So do have a look at that and see what might suit you. And then finally, just to mention our podcast series of Walk and Talk Improvement. We have a new podcast episode to mark the World Patient Safety Day, and certainly would encourage people to check that out. There are now 7, I think, podcasts available, and they really cover a very broad breadth of all things QI. In general, I think you can connect with us on Twitter, and if you do miss any of our sessions, you can check back on our YouTube channel. And particularly for today, again, we'd encourage you to become active on Twitter. I'm not sure if I can take myself to calling it X just yet. We're going to still call it Twitter. So yeah, please do engage on social media, on Twitter, and share your thoughts, and we will be tweeting from today's presentation.
Great, thanks so much, John, and very welcome to everybody to today's session. So today we are discussing VTE, and what we're hoping to get across today are 3 main points to help you to understand the impact and epidemiology of VTE, how to risk assess and optimally prevent hospital-acquired VTE, and to help you understand the importance of raising awareness of the signs and symptoms of VTE. So we're very happy to have joining us today fantastic speakers that I know you'll enjoy as well. So firstly, Professor Fionnuala Ní Fhionlá, who is our National Clinical Lead for VTE, which is only one of many strings to her bow. We also have Anne-Marie O'Neill, who is the CEO and patient founder of Thrombosis Ireland, and indeed a thrombosis survivor herself. We're joined by Dr. Bibi Bassa, who is an emergency medicine registrar who's also studying her PhD in VTE and trauma, and she's coming to us from the Mater Hospital. And finally, we have Carol Walsh, who is an advanced nurse practitioner in acute medicine in Bantry Hospital. So delighted to have a fantastic panel today. They'll each be speaking, and we'll keep an eye on the chat between John and myself, and at the end we'll have a few minutes to ask them questions. So we'll be saving our questions until the end. But first, I will hand you over to Professor Fionnuala Ní Fhionlá who will introduce you to our session and kick off today. Thanks, Fionnuala.
Thank you, Roisin, and thank you to all the organisers for inviting us, so on behalf of myself and Anne-Marie and Bibi and Carol, to speak to you today, and hopefully to inspire you that venous thromboembolism is a huge patient safety issue within Irish hospitals. And it's absolutely terrific to see so many of you joining us today. And we all deeply appreciate all that you've done already for VTE prevention on behalf of your patients. You're all very, very welcome. So venous thromboembolism, or VTE, comprises deep vein thrombosis and pulmonary embolism and is really common. So recent data presented last year at VTE Dublin show us that 1 in 20 people will develop venous thromboembolism throughout their lifetime. And that's not all, because people who've experienced a venous thromboembolism event have a very high chance of experiencing lifelong debilitating complications as a result of having had this event. So I think you're absolutely right. It's in all of our interests, including our patients who we care for and their families and our own loved ones and families, to prevent VTE and not miss any opportunity to save a life and to protect health. And not just a patient safety issue, but VTE costs a huge amount to healthcare systems throughout Europe and is estimated, based on ISTH data, to cost up to €13 billion annually in Europe. Tragically, VTE remains the top cause of maternal death in people who are pregnant or postpartum. So the impact on a global scale cannot be underestimated. VTE causes 1 death every 37 seconds in the developed world. And we're all still reeling from the impact of the COVID-19 pandemic, which saw a massive impact on the coagulation system. And indeed, 1 in 5 people who are extremely unwell or who were admitted to critical care with COVID-19 developed venous thromboembolism. And these events contributed to death and long-term morbidity in so many of these patients. But today, it's our task to understand how we can protect our patients, our loved ones, from hospital-acquired thrombosis and its long-term effects. And what we mean by this is that any venous thromboembolic event that occurs during a hospital admission, but not just that, within 90 days of discharge as well. So hopefully, having whetted your interest, it is now my genuine pleasure to hand you over to one of the most inspirational individuals I have ever had the honour of meeting. She's an international reputation, and her ability to inspire has never failed to surprise me time after time. So it's Anne-Marie O'Neill, who is a patient of VTE herself and who is the founder and CEO of Thrombosis Ireland. Thank you, Anne-Marie.
Thank you, Fionnuala, for that lovely introduction. And thank you, everybody, for this opportunity to share the patient experience of VTE in Ireland and the absolute importance of the QI and scientific approach to improvement. There is no doubt that we've improved in some areas since I experienced my PEs back in the 90s, but it's still a hospital lottery on quality of prevention, diagnosis, treatment and care received by VTE patients in Ireland. To date, we have no real complete idea of the scale of the issue because there's been no easily attainable national data. And how can we measure improvement without it? It is important also to remember that a VTE's patient risk extends 90 days after discharge when they're home alone. And pregnant women and new mums are not in hospital being monitored most of the time. We need the patient working with our healthcare professionals to ensure their safety and best outcome. In order to achieve this and to help you in your work, there is a need for a national public awareness campaign so we can all be informed of our risk and the signs to look for so we can look out for each other. Amy's story is the perfect example of this. She had a really lucky escape. Amy contacted us and when she was 12 weeks pregnant, she was suffering severe headaches, and she went to her GP and was given antibiotics for a sinus infection. And the headaches continued, and work colleagues and family members around her didn't actually realize the risk that she was in, didn't realize it was a symptom of a blood clot in pregnancy. They had no idea, and it went on for weeks. She suffered really severe pain and pressure in her head. She eventually went back to her doctor, who sent her to A&E. And initially in A&E, the doctor attending didn't want to do a CT scan because she was pregnant and didn't actually think that she had a clot in her head. But on the change of shift, she got a new doctor who actually took her really serious. And she did advocate for herself really strongly because she was in so much pain. And the CT was eventually done and a CVST was diagnosed. If there was more awareness, both within her family, within her work colleagues and friends, her husband, her parents who live next door, nobody had any idea. So a national awareness is really, really important. Luckily and thankfully, I can say that Amy delivered her baby a couple of weeks ago, and little Michael is thriving and all is fine. But really, we could have lost 2 lives. She was just lucky it was caught on time, and she's no residual damage to her brain, thankfully. The second thing really is there's a need for a healthcare professional and patient VT education program. And this, again, is all part of quality service, in my opinion. And I'll give you 2 reasons, 2 stories to kind of back it up. So we've Millie's story. Millie was 18 and she bought a skateboard and fell off and broke her ankle. And she needed surgery. So she went to hospital, had her operation, but before she left, a nurse took a few minutes to give her a blood clot alert card to discuss the signs and symptoms and the fact that she just had surgery and was now immobile in a boot, that she was at higher risk of a blood clot, and told her the signs to look out for. Millie started to feel pressure and pain in her leg before she was to get her second cast on, and remembering what the nurse said, mentioned it to the doctor when she went back to get her new cast. Luckily, he decided to do a scan and a DVT was diagnosed. So she was caught before it travelled, before she was put in serious danger. This is a good news story. This is an example of why quality care works and saves lives. On the other hand, Niall, who's 23 and from Kilkenny, fell and hurt his knee and needed just a simple operation on his knee where he just had an elastic bandage on afterwards. But beforehand, he did have a pre-op assessment. His mum was with him. No mention of the risk of blood clots and the signs to look out for. So 6 days in, Niall is having discoloration in his leg, he's having swelling, but he just thought it was as a result of the procedure, and he had an appointment to go back after 12 days, so he wasn't worried about it. He said to his mum, I think I'll go back to college, I'm missing too much time, so she dropped him to Waterford. By the time she got back to her house, she got a call from the college to say he had collapsed. And by the time she got back to Waterford Hospital, where he had been taken in an ambulance, Niall had passed away. Her son was 23. And this woman lives with this absolute guilt and, just sickening guilt ever since, because she feels she should have done something, but she wasn't informed. She didn't know. He didn't know. And really, she feels it was such a preventable death and such a waste. So these are 2 stories of taking the minute to give a little bit of information and just absolutely no information, and the impact that this can have. And by the way, it's not just death. If people are not diagnosed fast, they're left with possibly debilitating pain for the rest of their life. It's so unnecessary. If a blood clot is actually found quickly, people can have a really good recovery. The drugs are amazing, and usually it's just for 3 to 6 months, and then they're fine. They can get on with their life. We just need to inform them of how to protect themselves going forward into the future. The third point really is there's a need for every patient to be VT risk assessed. How else will we know their risk and know to take action to prevent a blood clot occurring? This should not be a suggestion or a gentle request. This needs to be prioritised. Eve's story is a perfect example of this. Eve fell on the steps of the courthouse down in Limerick, and her parents dropped her to A&E to get a check. She really thought she'd broken her leg or ankle. Her leg was very swollen. She said it was like a ham. And she was in A&E for 17 hours. She expressed her concern that it may be a blood clot because her mother had had one 10 years previously, and she remembered what the leg looked like. Her mother had had one in pregnancy. She kept saying, could it be a blood clot? Is it? And she was dismissed a number of times. She was discharged after 17 hours, having had an X-ray to rule out a break. And within a couple of hours of getting home, she collapsed. An ambulance was called, but Eve didn't make it. Now, Eve, had she been risk assessed, it would have been flagged. Number one, she had a lower limb injury. Number two, she had a family history of blood clots. Number three, she was carrying some weight. And number four, she was a smoker. I mean, I'm not a doctor, but if I look at those four risk factors, I'm thinking, you know, maybe a little bit of prophylaxis or something might have been. I'm not a doctor, so I don't know, but I'm just saying, really, in my opinion, Eve could she was also on the pill. So she had an absolute load of risk factors. And it was so unnecessary, really unnecessary. And particularly when she had an idea herself, but nobody listened to her. So this really says that there has to be a really strong education program for our healthcare professionals, from the admitting doctors to radiologists to physios to GPs. Everybody needs to know about it. And not just the healthcare professionals, but the patients, the families, the country. Every household needs to know about this. To watch or read any of these patient experiences, go to our website, thrombosis.ie, and there's lots more stories there to tell you why you need to do this work, why it's amazing, why it'll work, and what a difference it'll make and how it'll save lives. Patients and healthcare professionals, awareness and knowledge, and strong implementation of the risk assessment will save lives, reduce disability and death in our patients. Together, we are stronger. Thank you.
Anne-Marie, thank you. Thank you so much for that. I can hear the pain in your voice as you remember, you know, the story of, and we send love to their families, Niall and Amy. And also thank you for sharing Millie's story, because all of these three examples, these three people show us why there's no excuse, why it's crucial that we never miss an opportunity to educate. And thank you for all that you have done personally to develop resources with the HSE, with the Ireland East Hospital Group, in every language, you know, to make sure that we don't miss anybody. And let's carry that flame forward. Thank you, Anne-Marie.
Thank you.
Before we move on, let's reflect on all that Anne-Marie has shared with us, and let's collectively send our love and condolences to the families of Niall and Amy, whose stories Anne-Marie has shared. And of course, thank you to everybody who is sending hearts and messages in the chat. And if anybody, absolutely, Kathy, it was an absolutely powerful message and also a call to action. So I think it's very clear what the messages are. This is not just a QI exercise. This is about preventing death, you know, preventing the effect of tragedy on families and on the wider community. I just cannot imagine what those families are going through, Anne-Marie. And thank you for sharing it. Sorry, Anne-Marie, were you going to share something else?
Just to remember, really going forward, that all of the statistics, really we're talking about people, we're talking about human beings, and how important the work that you're doing is, really, because you know, that nurse in Cork that just sat with Millie and took that 2 minutes. I hear all the time a reason why a lot of things aren't being implemented is lack of time, you know, lack of resources or whatever. I mean, 2 minutes out of your life to save 2 minutes to save a life. Really, you know, the time thing is really no excuse. We've got to find a way to ensure that every single patient gets that 2 minutes of care. Thank you.
And Anne-Marie, I couldn't express it better than Anne-Marie Phillips, who's just said, thank you, Anne-Marie, for a very powerful talk, which I won't forget. And now it's my very great pleasure to introduce Dr. Bibi Bassa, another complete inspiration, an absolutely brilliant clinician and scientist and QI enthusiast and soon to be expert. And Bibi's leadership has blown us all away. She is a trainee in emergency medicine, but has really rallied the troops in terms of demonstrating what a team can do in terms of preventing VTE in a high-risk patient population. Dr. Bassa is currently conducting an MD in trauma and venous thromboembolism, and her work is phenomenal. And she is a VTE fellow within the Mater Hospital here in Dublin. So thank you, Bibi. I had the pleasure of listening to Dr. Bassa speak this morning at an international conference addressing venous thromboembolism prevention, diagnosis and treatment, including some of the thorniest issues that we can experience in the VTE setting. Isn't that right, Bibi? You know, the area of trauma is, you know, one of the highest risk issues that we can face as a clinical community. Why is that, Bibi?
So I think, you know, VTE, as we know, hospital-acquired VTE is associated with significant morbidity and mortality. Patients who suffer VTE have the highest impact in terms of disability-adjusted life years lost. In trauma patients, it's more complex because of the competing parallel bleeding risks that go associated with it. It's often difficult to decide when the window of bleeding has dropped and when the window of thrombosis, meaning when a patient is more coagulant, increases, and finding within that window to prevent VTE and PE. Often in these patients, because of these competing VTE because of these competing bleeding risks, these patients go without any thromboprophylaxis for prolonged periods of time. More importantly, the risk assessment models that we would use in patients, medical and surgical inpatients, are not validated in trauma patients. It's therefore very difficult to be able to identify those trauma patients who are particularly at risk. More importantly, the guidelines that are available at the moment are based on level 2 and level 3 evidence, meaning they're not as strong and robust as what we would like to see in a validated guideline for patients. But having said that, it still doesn't mean that this is a topic that doesn't warrant all our urgent attention, largely because in the absence of any thromboprophylaxis, trauma patients have a 1 in 2 risk of developing a DVT. And in those trauma patients who survive the first 24 hours of resuscitation, PE is one of the leading causes of death in this cohort. Now, I understand this is complex and I won't delve into the deep science behind it, but the reason why I like to bring this back to QI and the absolute benefit, so QI can be a really important tool. So what QI allows us to do is, number one, it allows us to access robust data. It asks us to do a deep dive into understanding trends and incidence rates within our population. And this allows us to identify two things. It allows us to identify patients who are at risk. And number two, it allows us to identify vulnerable patients who are often left out of routine VT risk assessments. More importantly, with stakeholder analysis, it allows us to identify early adopters, meaning it allows us to find people who would be willing to engage with us and champion the change that we want to. We know from NICE guidelines and the ESC guidelines that there are guidelines for managing DVT and PE. But VTE is very much work as imagined versus work as done. It is impossible to apply a blanket guideline to your system and expect results without understanding both the system, your processes, and the microsystem that is supporting your environment. We know that DVT prophylaxis works. It is effective at preventing hospital-acquired VTE. But who is responsible for this, number one? And number two, who is responsible to ensuring continuity, discontinuation, and the most important, patient education, is difficult to understand without fully going through your system. So you can see on the left, on the right, is a fishbone diagram. And this is a simple tool that we used in being able to identify why VT risk assessment was not being done in the trauma patient. And from the plethora of reasons that you can see identified, and this went on into an even bigger sheet, is that the causes are innumerable. That when we start to identify them, we immediately start to think of solutions. And this allows us to then prioritize our PDSAs, small little actions we can make to see if they make a difference. So the benefits of QI to prevent VTE in our local hospital: number one, data. Understand your population, understand the incidence rates, understand trends, and understand who is your vulnerable patients. Number two, understand system capacity. There is so much you can ask of a nurse to be able to risk assess, to be able to record patients' vital signs, to be able to administer medication. So know where there is a weakness and how it can be filled. Understand current practice. What is variation between departments, between surgical, medical departments, trauma departments, and understand why this is happening, as opposed to being reactive and didactic and trying to change it without understanding. Identify areas of opportunity. And most importantly, something which I learned from QI: turn wasted time into value-added time. If you can see an opportunity for discussion between a doctor and a patient, if you can see opportunity to pass a patient alert card, use that as an educational tool, as an educational opportunity, as opposed to nothing. And this was the project that we undertook as a team. We wanted to beat the clot in trauma patients, and we understood that a lot precluded us from being able to reduce preventable VTE rates in the trauma population, largely because it was impossible within a 6-month period to understand when surgeons would allow us to start thromboprophylaxis, when they would feel the bleeding risk would be less than the VTE, than a thromboembolic risk. But what we did know is that there are proven ways for mechanical prophylaxis. We know that intermittent pneumatic compression is the gold standard and should be used in trauma patients over and above graduated compression stockings. And if graduated compression stockings are used, they should be used correctly, graduated in terms of pressure. So what we set out to do was to ensure that risk assessments were completed for all trauma patients. We wanted to identify a service that would be tasked solely with the responsibility of VTE risk assessment. We would provide the training to risk assess on a daily basis and initiate correct prophylaxis. We engaged with pharmacy to increase the supply of both mechanical and pharmacological prophylaxis. The long-term aim was to reduce VTE risk for admitted major trauma patients and improve their long-term prognosis. And as you can see, this is a multi-dimensional project. It didn't require one stakeholder. It required numerous people on many different levels. It required consultants, it required CNMs, it required the help of pharmacy, clinical engineering, as well as SHOs and junior early career doctors to be able to ensure that this was happening on the front line. And so what was invaluable to us is understanding fully the process and the supporting microsystems to the emergency and trauma departments. By doing this, we were able to identify opportunities for change, identify opportunities for VTE risk assessment, and to be able to result in increased risk assessments. So essentially, what we came to the conclusion is that it is not impossible to be able to improve VTE risk assessments within a population where there are competing bleeding risks. Although there is no ratified guideline, ability to understand our population and to understand the local trends and to be able to find early adopters and champions of change help us in promoting VTE risk assessment. And in order for other hospitals to do equally the same, using the QI tools as opposed to any other process allows you to work quite in a very systematic way in understanding the needs of your population. So World Thrombosis Day, 13th of October. It's a fantastic opportunity for someone to commit to a VTE QI project and improve VTE risk assessments and prevent preventable VTE in your population.
Thank you so much, Dr. Bassa. As always, your leadership is absolutely remarkable. You've brought together a team at all levels of our hospital to deliver improved patient safety on behalf of our patients. I know I speak for every single one of us on the panel when I say you are a complete inspiration. And thank you for highlighting that World Thrombosis Day will take place on 13th of October. Our next speaker, and it's a real pleasure to introduce her, is Carol Walsh, who is an advanced nurse practitioner in Bantry University Hospital. It was our great pleasure to meet Carol and her phenomenal team when we worked under the leadership of the team led by Dr. John Fitzsimmons in terms of the postgraduate diploma in VTE. And what she has achieved is nothing short of remarkable. So handing over to you now, Carol, We're looking forward so much to hearing from you and what you've achieved using QI methodology.
Thanks, Finola. Thanks so much for having me here. So as Finola said, my name is Carol Walsh. I'm an AMP in acute medicine in Bantry General Hospital, and I'm going to give you a quick overview of a quality improvement project that I was involved with along with my colleague Emer O'Sullivan, who is the Quality Risk and Patient Safety Manager here. So our QI aimed to reduce the rates of hospital-acquired blood clots in Bantry General Hospital. So what was our problem? As we know, roughly 63% of all blood clots are associated with a hospital stay, and we know that around 70% of these are preventable. The national rate of hospital-acquired VTE in 2018 was 8 per 1,000 bed days. However, in Bantry, our rates were quite high at 32.2 per 1,000 bed days in 2022. So we had a bit of work to do. So we started our QI, we engaged all our relevant stakeholders to inform everybody that this QI would be starting, gain buy-in, get support. We then started to assess the actual problem to see what the causative factors were. We did local audits which showed poor results on VT risk assessment rates and on the prescribing of thromboprophylaxis. We surveyed junior doctors, which highlighted workload as an issue, and also there was some anxiety around prescribing anticoagulation. We then surveyed patients to see what methods of education or information on their health they preferred to receive. We then brainstormed using fishbone diagram to find out the issues that were blocking us. This showed poor knowledge on hospital-acquired VT, the lack of local guidance, workload and time constraints. We mapped our processes. We looked at the patient's journey in the first 24 hours, and this showed a lot of variances on when and if the risk assessment, the prescribing of thromboprophylaxis was done. We then did a process map on how we would like our system to look. So what were we trying to accomplish? We developed our SMART aim, which was to reduce hospital-acquired VTE to 0 for all admitted patients attending Bantry General Hospital by June 2023. We used a Pareto chart to show us where to focus our efforts initially, and this highlighted risk assessment and prescribing of thromboprophylaxis as areas to improve. So these became our main objectives. We monitored the local rates of hospital-acquired VT, the number of risk assessments completed, the number of risk assessments completed correctly, and the rates of thromboprophylaxis being prescribed. We also monitored hospital incident forms for any major bleeding events. So what did we do? We ran numerous PDSA cycles using interventions developed from our driver diagrams, and you can see there was 3 of them there. One was for identification, the other one mitigation and escalation of the risk of hospital-acquired VTE. We did information stands, with education sessions. We designed posters for staff. We put up posters for patients, patient information cards and the QR codes from Thrombosis Ireland. We made mouse mats, desktop screensavers. We even started a VT Preventer of the Month competition. We then audited twice weekly. We audited medication charts to see the risk assessments on the prescribing. And sometimes we found that our results actually guided our next PDSA. Okay, so here are our results to date. So the first run chart there, you can see that looks at the completion of VTE risk assessments, which increased from a median of 10% to 78%. You can see some dips there, and they correspond with NCHD changeover, and you can see the rates then slowly improve as education and interventions take place. The next run chart there then is our prescribing rates, which increased from a median of 43 to 89%. And I don't know if you can see it if it's big enough, but more than a few times we hit 100%, which is great. And if you look at both run charts, you can see that there's very similar pattern. You know, if the risk assessment isn't done, or if the risk assessment, if the rates are high, the prescribing rates are high. The bar graphs on the bottom there, look at the hospital-acquired VTE rates. These rates are reported monthly, and they're 3 months retrospective. But older data is quarterly, so we converted to quarters just so we'd be able to compare them to get more than 1 year. And as you can see there, Q1 and Q2, the rates have reduced from previous years, which is great. Also, 100% of risk assessments that were completed correctly, and we've had no major bleeding events reported. So this is the learning we gained. So we had some difficulty with the data, the VTE data. We knew some of the rates for some of the months, but not all. There were some gaps, and we think this is probably likely to COVID and to the cyber attack. It came from various sources. There was QDR data, then MDR data. There's also a HIPSA report which comes out with data. And as I said earlier, some of the data was initially quarterly and then went monthly, so it was hard to understand. And also, like, some of the data isn't final. They usually finalize it at the end of the year. So this took me a few months to get to grasp with. I was very lucky to have Emer with her experience in quality, but I think for anybody looking to do this, if you've no experience of this, do get in touch with your quality manager early on if possible in the project. And also, I would recommend to try and translate it into what it means on the ground, because 32 per 1,000 bed days is a little bit hard to kind of grasp what does that actually mean. Like actual patient numbers would be great. And I'd also recommend pulling patient charts to get a better understanding of what went wrong, if anything, and what else could be done to prevent it. Healthcare knowledge, just don't presume that healthcare workers have a good knowledge on hospital-acquired VT, because we actually found that there was a very poor level of knowledge surrounding hospital-acquired VT, the risk factors and the prescribing. If you're going to put education in place, I recommend starting very basic to cover everybody. I think if people have a better understanding of the risk factors and the impact of it, you're more likely to get better buy-in. We also had a little bit of resistance, very, very little, but I just wanted to highlight that we did like the usual things to get them on board, involving them, providing extra one-on-one education. And in an ideal world, everybody would get involved and get on board early, and you wouldn't have any problems. But sometimes you do have laggards, and you just kind of have to keep going with your QI with them not on board, and just hope that eventually they will get on board with you. And my last thing there is education and empowering patients. Don't underestimate the impact of this. If a patient asks you about the risks of a blood clot in hospital, you'll 100% do that risk assessment, and you'll 100% put the stuff in place. I know myself based on my own experience. That is my presentation. Thank you for listening.
Absolutely brilliant. Thank you so much, Carol. What you've achieved is going to improve the lives, and I'm certain will have reduced harm and promoted recovery, just as you set out to do, Carol. And again, as I said, for Dr. Bassey, your leadership and your ability to influence and to win hearts and minds is at the very centre of what you've achieved on behalf of your patients. It's so clear that you and your colleagues cared deeply about preventing harm. Thank you. And with that, I'll hand back over to Roisin and to John. Thank you so much.
Great, thanks so much. And thanks so much to all of you as our speakers today. Fantastic words from all of you, and no doubt a reflection. There's been fantastic work done around the country in addressing VTE. So to have your examples today and to share your stories, indeed, Anne-Marie, it's been wonderful to hear them. I think Kira really got it right in the chat. She said it's wonderful to see tackling prevention in such a high-risk population and illustrating how QI tools enable this. So well done. We got several well dones, and as you said, Fionnuala, there's been lots of hearts and clapping of hands. So just mentioning on the prevention, and we do have a couple of questions coming in, but I had a query myself really to go back to Anne-Marie. When we talk about preventing VTE, you talked a lot about quality care and how we can ensure quality care. What do you feel is the most important thing a healthcare professional can do to support patients in preventing VTE?
I think communication is really important. So a patient needs to understand what they've just been diagnosed with, or what their risk is. Let's say they haven't been diagnosed yet, but they're going in for a surgery that is high risk. If you understand that there's a risk and there's certain things you need to look out for, I think if you're working together as patient and healthcare professional, you've got a lot of, a much better chance of both prevention or a better outcome should it happen. Early diagnosis. So I think really communication is paramount, really important. And I suppose to ensure that you risk assess every single patient, even if they're not being admitted. I think because in a lot of cases, people are, put in a cast and sent home. They're not admitted. So we're missing those lower limb people. Our girls who are pregnant aren't coming into the hospital as well until maybe at 20 weeks, or I don't know what, I can't remember the first visit. It's that long since I had a baby. But they don't really see a doctor for a while. So all of a sudden they're pregnant, but if they're not aware that they're at risk, they can't protect themselves. So I think we need to communicate nationally. We need to communicate individually. That'll be my thing. Thanks.
Yeah. Brilliant, Emery, absolutely. And in QI, we often talk about communication being one of the cornerstones of QI, the importance of communication. But when we think about QI and why a QI approach, and I suppose this is going back to something you said, Dr. Bass, as well, Bibi, around why QI. You know, you could have implemented your project any number of ways. You could have used any approach, any theory, implementation science, project management. If you knew where you wanted to get to, you could have even used your lovely fishbone diagram in a different approach. But why QI, and why has quality improvement made that difference in implementing what you wanted to do?
To some degree, you know, naturally all of us who don't have a very extensive training in it. But what I can speak to with QI, and, you know, what was in my reflection, is the iterative cycle of PDSAs is what makes it so invaluable. And you might not know where to start, but you can start very small, and that gives a lesson in and of itself. And that lesson drives the next PDSA. And as you learn more, you're learning within your own local population. You're not going out to try and apply a generalizable rule to a large, patient group. It's your own patients. So you're learning within a very familiar environment, and you're for us, especially in trauma population, very important, because a lot didn't work. You know, we only have 10 minutes to speak here, but a lot actually didn't work in some of the PDSA cycles. And so the only way you could was having your little book of Excel, you know, PDSAs, to be able to see what is the next cycle, what is the learning I can take from that. So I think number one is the tools, but number two, I think it's the fact that PDSAs in and of themselves just grow into a much longer learning journey.
Yeah, absolutely. Those small iterative tests of change. You're not waiting on the one massive implementation project. You can test, and then you can adopt, abandon, adapt as need be, and just test each change and build on the changes. Yeah, absolutely. And building on those changes, and Carol, I think I'm just pivoting to you now, building on those changes and having the spread and sustainability of QI. I mean, Carol, in your work, did you look at sustainability from the outset of the project, or how did you feel you could build sustainability into that fantastic work you were doing in Bantry?
Well, we kind of wanted to, obviously I have another job, so I needed to be able to give it to somebody and keep it running and just keep an eye on it in the background. So one of the things we've done is, well, we will be doing, is the NCHDs are always looking for audits. So we're going to give them a quarterly audit of the VTE risk assessments and prescribing, as I've been doing them. And when you're doing the audits yourself, you see the mistakes, and it's also the learning in it. Ideally, in an ideal world, I'd love a VTE CNS. I just think there's a massive role there. And as Anne-Marie said early on, the education, like mandatory, I suppose, HSE education for staff that everybody knows, because I know so much more now than what I did know before I started this. So, you know, there is poor knowledge on the ground. I think that's, you know, increasing knowledge, putting in standardized audits, and maybe having a role there for someone, I think, is a great way to sustain the change.
Yeah, absolutely, Carol. I couldn't agree with you more. And we do say often in QI that, you know, some of the best QI facilitators facilitate themselves out of a job, so that if you really do have the sustainability built in, you could step away from it. You could win the lottery and move to the Maldives, and your QI will grow and strengthen even without you. So you've given us a great example of that. We have a few comments come in on the chat. A fantastic support for everybody, our panel. You know, great presentation, super presentations. A lot of people will be sharing this with others and looking back on this. Seeing there, great to get the NCHDs involved in the audits as well. What's the best way to capture VTE rates in resource limited settings? I think maybe Professor Nianla, would you have thoughts on that, on the best way to capture VTE rates in resource limited settings?
It's a great question, and I can't recall who posed the question, but just to make everybody aware, there is actually, through phenomenal work by a very wide team within the HSC acute division and QPST, there is a KPI measuring the rate of venous thromboembolism associated with hospitalization, and that's objectively confirmed VTE. That's being confirmed to be due to hospitalization or indeed suspected to be due to hospitalization. And that measures the if they look up the metadata, that shows them how that is captured using HYPE data, big data, and measures the rate per 1,000 inpatient discharges with the length of stay of 2 or more days of VTE occurring during hospitalization. And I think this question is particularly important because, at the very beginning of today's conversation, we reiterated the fact that VTE is one of the leading causes of preventable death and disability in our hospitals. And as everybody has powerfully stated today, we must not miss an opportunity to save a life. And ultimately, it's this safety that we're trying to achieve. It's impacting that national KPI that we're trying to achieve. So your excellent commentator can access that resource and communicate. And from speaking with my national lead hat on, we know that we need more local champions in terms of really delving into the preventability of hospital-acquired VTE, which I appreciate requires a lot of work and resource. So thank you for that important question.
Yes, absolutely. Thanks so much for that question, and thanks for your response there, Professor Nyanla. We're getting a bit tight on time. I know there's a couple other questions that are coming in both privately and publicly on the chat. There's quite a few of them. So if you do have questions after this, if you have any questions around QI, you can get in touch with our team on qps.improvement@hsc.ie. And any other questions, you can direct them to our QPS TalkTime email address, and we will redirect them accordingly to have them dealt with. So apologies, we are tight on time, but we had some fantastic speakers today. So again, thank you to Professor Fionnuala Ní Aonla, to Anne-Marie O'Neill, to Dr. Bibi Bassa, and to Carol Walsh for joining us. And thanks indeed to all of you for joining us today. I'm going to hand you back over to John, who is going to wrap up our session. Thanks so much.
Thanks, Roisin. And yeah, lots of great questions coming in there. And there's one I liked here, just I'll mention it before we close up, just from Cecily Reggie, which is how do you make sure the risk assessment is done? Because the risk assessment seems to be key, I think, doesn't it, to a lot of all the other good things happening after that. And she wonders, should it happen in, where would you put the form? Is it in the drug chart or the medical assessment form? And as I was reading that question, I was thinking, how would you know? I mean, the only way you could really know is to do, as Bibi and Carol were telling us about, is to do some PDSAs, because, I think how it works where you are is going to be different from how it works from somewhere else. So the important thing is that the risk assessment is done, but it doesn't necessarily have to be the same everywhere. It has to fit in, like Bibi said, with the work is done rather than the work is imagined. Fionnuala, you wanted to come in there before we finish up?
No, I was just giving you a thumbs up, Dr. Fitzsimmons. That's precisely right. Sorry, yeah.
Great. Well, look, well done, everybody. And it's a pity we can't stay longer, but I'm afraid we have to go. We'd love to come back and talk about this again sometime. So well done. So again, if you missed today's presentation, you can watch back on our QPS YouTube channel. So all of today's recording, but all the previous recordings will be up there as well. So put a date in your diary for next week. If you scan the QR code, we will be at the IADNM conference, and Helen Bevan, who is speaking at the conference, is going to do a special QPS talk time. So anybody who's aware of Helen knows that she's a really wonderful speaker and thinker on QI. And so that would be really great. I think if you get to the conference, you may get to see her in person, but if you can't, she'll be doing a talk time on creating tomorrow today, how to prepare for a radically different future. So I really encourage you to join us for that. And that's it. I really just want to thank